So our first speaker is Dr. Marta Cremonesi. She comes to us from the European Institute of Oncology in Italy, and the title of her presentation is Emerging Radiopharmaceuticals.
Thank you very much for the presentation, and thank you very much for the invitation, and to all of you that are here so early in the morning. So this talk is about emerging radiopharmaceuticals focused on dosimetry, which is my field. The rationale of theragnostics is based on the efficacy of therapy that correlates with the target expression and is evaluable from a correspondent diagnostic agent. And so image-guided radionuclide therapy is increasingly recognized and applied as a promising approach to treat cancer, with excellent results in the last years that show definitively the need of this therapy. And radiolabeled molecules for targeted radionuclide therapy should have specific characteristics, as you know, specifically high affinity for the target, I mean, a very strong strength binding, and a high tumor to non-tumor ratio, of course, this is the consequence, and excellent radiolabeling and very high stability. So these are radiochemical important characteristics that we have to check and to deal with. When we use an image surrogate for dosimetry in targeted radionuclide therapy, the same molecule, including the chelator, any single piece of the molecule, and the conditions of the therapy has to be reproduced to properly assess the biokinetics and the quantity of activity that is in each tissue. Of course, the labeling of the radionuclide must be chemically very similar with physical half-life and with a therapeutic one, and the physical half-life has to be compatible to the biological half-life of the molecule, of course. So this presentation will show three examples in particular, as there are so many new treatments and so many new molecules I had to choose. And so first we'll see an example with lutetium monoclonal antibodies for non-Hodgkin lymphoma patients. Then we will focus on alpha PSMA and then on alpha PRT compounds. I would like to show you the results of this interesting study, not because it's exactly a therapeutical, a theragnostic within the theragnostic frame, but because first is a radiopharmaceutical which uses lutetium, not in the classical standard 7.4 gigabecquerels per cycle. And so it is applied to non-Hodgkin lymphoma patients, so to a monoclonal antibody, and this study has been started in Oslo, in Norway, and especially this pharmaceutical provides a very good example of an emergent treatment, very well conceived and having accurate dosimetry. Actually, the group published many studies showing first the way of the results for red marrow absorbed dose in Hodgkin lymphoma patients with this lilotomab lutetium antibody. And then they studied the tumor absorbed dose in the patients, showing results similar to other radiopharmaceuticals that have been more complicated to apply. And then they study more carefully also the biodistribution and dosimetry from the phase 1 study. They showed also the difference between pre-dosing and non-pre-dosing with cold antibodies in patients as regards the dosimetry advantages. And then they showed also the results, the clinical results based on the response, very good response for patients in non-Hodgkin lymphoma patients. And lastly, the myelosuppression in patients was shown to be predicted by red marrow dosimetry. So this was, for me, from my point of view, but I think, I hope that also you can appreciate the effort and also the good results. So the first aim from the clinical point of view after preclinical studies was to assess quite carefully the red marrow absorbed dose. And so they decided to consider two methods. First, based on the SPECT, considering the activity accumulated in the vertebrae L2, L4. So they evaluated the activity concentration based on this hypothesis. And then they also considered the evaluation from a surrogate red marrow dosimetry based on the blood. They measured the concentration in the blood, and they assessed the time activity integration coefficient for the blood based on this assumption. However, they observed in images the uptake in the red marrow, as you maybe can appreciate here, without and with pre-treatment in the antibodies, so they could evidence the difference and derive the red marrow absorbed dose for the patients that were injected in different categories from 10 to 15 megabecquerels per kilogram. And so finally, the absorbed doses were in total about 0.7 to 1.3 grays in the first case and 1.6 to 2 grays in the second case. So there were doses that were close to the classical thresholds for hematological toxicity. So, and here are seen the correlations that they observed based on the SPECT images calculation for the red marrow doses as regards the thrombocytopenia grade and the neutropenia grade. So these are quite good, very good correlations, I would say. And so they observed also that non-imaging based methods were not good to describe any correlation. So in this case, for this monoclonal antibody, the first method based on SPECT was preferable. And here in these two papers, they report the details. So this is nice because all the information is shown actually to the reader, showing the activity in L2, L4 vertebrae, the half-life, also the absorbed doses, and the total doses based on the activity injected, and then comparing in another paper with the final treatment decided to be of 20 megabecquerel per kilogram. They compared also the absorbed doses to the red marrow of their monoclonal antibody as compared to Bexar and to Zevalin, so in 4 different radionuclides. And then now I would like to consider some issues about alpha emitters for radiopharmaceuticals. Of course, you know that these are absolutely emerging radiopharmaceuticals of major interest for all the community for radionuclide therapy due to the high linear energy transfer. And so due to the short range in the matter, this allows to increase the probability of the double-strand DNA breaks and to improve the cytotoxicity to the cell nuclei by localized damage. So this provides a potentially important point to fill the room for improvement for safety and efficacy. Alpha experiments have shown RP values between 3 and 7, according to the MERD and 22 and to the ICRU 96. The point that is important to consider is the physical half-life of the alpha emitters, which has to be compatible, again, to the therapy we want to consider. So not only to the administration, but also to the production, to the molecule pharmacokinetics, and the time needed to apply therapy. So special interest are these radionuclides, for example, actinium with 10 days of half-life, actinium-225, Star-22111 of 7 hours of half-life, lead 2020, 11 hours of half-life, and thorium with 18 days. So there are differences in half-lives. So in principle, actinium and lead are more likely to be suitable for small molecules and peptides, which are characterized by fast pharmacokinetics, typically of a few hours, some hours. Instead, thorium and actinium seem to be more suitable for monoclonal antibodies or ligands molecules that are longly circulating in the body before reaching the target. So there are many fascinating studies ongoing in terms of preclinical studies and clinical studies. In the first case, the results are absolutely very important to be considered and to be provided because they represent simulations and offer models and sources of most important information, although this information is not directly always applicable to clinical, to the patient directly, but and may not be exhaustive, but it's fundamental. And clinical studies, of course, then have to be performed and indicate actually superior potential for anti-cancer therapy as compared to beta emitters for the moment. There are, on the other side, very much issues to be deepened and things to be understood, which represent a challenge. Molecule stability of the daughter, and the possible fate in case the daughter does not remain anymore labeled to the molecule. Imaging is not very easy and directly feasible. It is also to understand the requirements for improved efficacy and the potential risk for toxicity. And there are, of course, issues on dosimetry and radiobiological evaluations related to the non-uniformity at the microscopic level. So the mean absorbed dose and mean evaluations at the microscopic level cannot be necessarily representative. So we have to deal with that. And because there are many biological issues outcomes that can concur, and even some specific patient issues may be much more than for beta emitters that may change the outcome as compared to what we could think with the mean absorbed dose evaluations. So in general, more empirical data are needed for dose toxicity prediction. Here is an example of dosimetry applied with actinium PSMA. Actinium PSMA has shown to be of great interest and for efficacy in prostate cancer in patients maybe not even responding to lutetium, as in this case. And the major problem is the risk of xerostomia. Apparently, the risk is limiting the therapeutical window. And so one of the issues that this group wanted to evaluate was the possible estimate of the limit dose to avoid a possible toxicity. However, not having direct dosimetry, direct imaging with actinium, they extrapolated the dosimetry from lutetium information in the patients they had, and to evaluate in particular the absorbed dose and the submandibular glands for these patients. This is the decay of the physical decay chain for actinium. And so some hypotheses were considered, the similar uptake governed by PSMA carrier. So they had also to correct, of course, for the physical half-life. And actinium was assumed to be in equilibrium for all daughters. So the absorbed doses related to the daughters were also included in the evaluation to consider the cumulative time integration activity coefficient for actinium. The RBE value was considered to be 5 according to the literature, and all the contributions from alpha, beta, and gamma radiation was summed up according to the branching. But I would like to highlight that this is an assumption that experimentally, maybe especially in preclinical studies, should be verified. But this was a proposal, a model that I found was interesting. I don't want to go really with in details with the equations, but very simply described the scheme. The bed formalism was the biological effective dose formalism was derived for high lead emitters according to brachytherapy, and so they obtained the RBE for these high lead particles, extrapolating the equations, and then they obtained the initial dose rate, and finally the biological effective dose for these high lead particles, summing up all the contributions for the daughters. And they derived the values, the amine absorbed doses extrapolated from lutetium images for, in particular, the parotid and the salivary glands, and then also for the kidneys, the liver, the red marrow, and so on. But the point was to get this number here, the biological effective dose, which was about 27 grays as a median value with some ranges, with this range of variability, and to check, to try to have some information derived from the external beam radiotherapy. So this BD was considered to be the same value as the BD for external beam radiotherapy, and was derived the equivalent uniform dose at 2 grays per fraction, because they had an NTCP value obtained from external beam radiotherapy to estimate the risk of xerostomia. So from the Quantec dose constraint of 26 grays for parotid glands, they obtained a biological effective dose of 34 grays, which was lower than the biological effective dose obtained for the radionuclide therapy. So the conclusion was that the treatment they were giving was less toxic, was under the limits of toxicity, and considering these are the NTCP values extrapolated from external beam radiotherapy. And in practice, the model probably was underestimating the risk, as actually the patients did not have xerostomia. But this is an example showing how we could have a rough idea of where we are in terms of toxicity without having direct experimental data from patients, and setting a new protocol for avoiding, at least at the beginning, high risks, and then maybe some change the activity if we think that we are in the safe side. Another important point is the couple of lead 2020 and used for targeted radionuclide therapy, which is not directly an alpha emitter, but is an in vivo generation of alpha particles, because within its decay there are 2 alpha emitters, bismuth and polonium. So this is interesting, and the half-life is about 10.6 hours. But for imaging, it is very interesting that we have the same lead of 2003, very useful for imaging, because there is a gamma ray at 2079 keVs with a high abundance, and the half-life is long enough to allow imaging and to allow imaging also by time. So it seems a perfect surrogate within the theranostic rationale to determine the pharmacokinetics, to identify the patients that can benefit from therapy, and also to evaluate the dosimetry for treatment planning with very good images. These are some of the studies, preclinical and clinical. These two are clinical, presented in this review 2020. Probably there are now much more studies ongoing. But what I would like to highlight here is, well, we have this radionuclide, and due to the energy, we also can derive useful information from what has already been published and established and diffused as guidelines for lutetium quantitation. So we are lucky on this side. Maybe some specific issues should be studied more in detail, specifically for this radionuclide. For example, the energy is higher than in lutetium, so maybe the high energy collimator might reduce the septal penetration. In any case, we have enough experience to handle this. But the question is are labeled compounds with lead 2003 really mirroring the pharmacokinetics of lead 2012? Well, there is some evidence for the tetochelator in particular that in about 30% of the lead decays, beta decays, the daughter of lead, bismuth, is released from the molecule due to recoil, and so it accumulates to the kidneys. And this has been shown some preclinical studies suggesting also that the kidneys could be protected by the injection of DTPA in order to reduce the accumulation of bismuth, but in preclinical. In any case, this point is a risk point, because that means that if we do not take into account this possibility and do have information about this, we would underestimate the kidney absorbed dose, which can be not a huge problem for some radiopharmaceuticals who are not excreting through the kidneys so much the radiopharmaceutical. For example, for monoclonal antibodies, in the majority of cases, this might not be such a big deal. But for some other molecules, such as the peptides, this is absolutely very risky. So we have to be very careful about the information we have on this, on the daughters, on the destiny. So, and the uncertainty of the release of bismuth atoms before its alpha particle emission leads to uncertainty in the dosimetry. So, in general, as a message is, by distribution studies comparing lead-212 and lead-23 specifically for pharmacokinetics, and have to be specifically studied for pharmacokinetics and the candidate for therapy. In any case, for radiopeptide therapy, lead has been applied in this study by Delpassant and colleagues. You can see very promising results showing that lead dotamtate with renal protection was very well tolerated with some adverse events, but the serious effects were not related to the drug, and they obtained also a very high rate of response according to REGIST. So this is a promising radiopharmaceutical. Dosimetry was not provided yet in this paper, but the authors say that will be provided in another paper. So I'm very curious to read the new paper. And they studied the stability of the bismuth. To conclude, this is just a reminder because in general, I read in many papers and also I've seen in some presentations that the authors, the researchers are very happy when they can say, oh, this radiopharmaceutical has a very fast clearance, so this is a good thing to highlight, to have a high tumor-to-tumor ratio, and a good thing in general for a good for improved safety. Well, I would like just to remind a paper that is quite old, but that showed me that this can be a thing to evaluate with carefully. Because yes, fast clearance means low irradiation of the whole body, on the bone marrow, and of all the organs that are not involved in the elimination path. But what about the kidneys and the urinary bladder? These can be critical organs, not only the kidneys, for serious, late, and irreversible toxicity. So this is possible. And even urinary bladder, even if it's more radio-resistant, this can be a critical organ too. And this is important, so to study the elimination rate and to evaluate the absorbed dose and the BED of organs involved in the elimination. And I'm telling this because if you can read this paper, I think it's still very important, and maybe even if it's not very recent, from Hazel Bryce. She was a very incredible researcher and in favor of dosimetry. One of the physicians that understood really the importance. She got this clinical trial with Olmium for irradiated bone marrow transplantation. Already did the red marrow before before stem cells transplantation. In patients affected by myeloma, and apparently the kidneys were not showing uptake, and the first evaluations were indicating quite low values to the kidneys, no more than 10 grays, and the urinary bladder, yes, could receive high radiation, but was not apparently such a deal. However, the clinical results showed grade 3 toxicity in 33% of the patients, and in 33% of the patients, renal toxicity with some deaths. So these are the images. She got the images, and she got the urinary concentration, activity concentration for whole urine collection. So instead of these models, and besides what appeared from the images at 2 hours, you can see a renal uptake here. Everything was being recalculated considering the very high dose rate, and they did found the very high dose rate, recalculated the values, and actually the absorbed doses obtained were at least doubled, with BED to the kidneys reaching more than 40 grays. So this explained the renal toxicity, and so I would like to conclude with that slide, and to thank you very much for your attention, especially at this early hour.
Thank you very much, Dr. Cremonesi, for that excellent talk.